Is there a need for intracameral antibiotics during cataract surgery?
Well, that's a good question. I should admit at the beginning that I might be a little bit biased because I was one of the first in the world to propose that we all use them all the time. And I'll tell you why I use them and what the research has shown. I use them because I like doing bilateral cataract surgery, and I was afraid that I would get a patient that might get an infection in both eyes. And an obvious solution from the early data we had in the early 90s was that these intracameral drugs will reduce infection rates. And over time, we've seen with successive studies, first from Gimbel and Gills, and then from Montan in Sweden, and then from the ES-Sierra study, and now globally with numerous studies, including about 8 million or more eyes, that intracameral antibiotics, whether you use ceftriaxone or vancomycin or moxifloxacin, all reduce the rate of infection by about 80%. 80% is a big reduction. And so when you end up seeing a patient and they ask you about their risk of surgery, and you can tell them their risk of getting an infection is less than 1 in 6 or 10,000 compared to 1 in 500 to 1,000, the patient's far more reassured. And also, as a surgeon, I'm much happier not seeing infections in my office frequently. And I think the last time I saw an infection was almost 10 years ago. So it's just, it's not zero, but it's really, really low. In our bilateral surgical society, we're down to seeing about 1 in 17,000 when we use intracameral drugs. And all the literature in the past few years has shown that probably the most effective one is intracameral moxifloxacin, which I guess perhaps by happenstance I was the first in the world to propose and use, and I've been extremely happy with it. I've done, I think, 9,500 patients, and I've had 0 complications from injecting it. The nice thing you see about it is that we all recognize that we have to sort of fiddle around in the patient's eye to do cataract surgery. And on post-operative day 1, all of us recall seeing some patients that had some fibrin across the membrane and a little bit of inflammation. And I can tell you that I haven't seen a single case with that since 1996 when I began to use intracameral drugs. And I think all of those are low-grade infections, which the patient fortunately overcomes. And when we use intracameral drugs, you just never see that. The eyes are just crystal clear the next day. So I'm very much in favor of them.
There are a few surgeons who are concerned about issues such as corneal toxicity tests after using intracameral antibiotics. What is your opinion on that?
Well, my opinion of that is all of the cases of TAS reported in the world generally occur because somebody changed something in your operating room and used something that wasn't particularly clean or prepared properly. So my response to that is I have never ever seen a case of TAS either using initially vancomycin while we could use it in Canada before 2003, and since then using moxifloxacin. As long as you prepare it well, it's fine. And I suppose you're from a company, obviously, and I'm turning it back to you that I praise you for preparing the world's only prepared syringe containing moxifloxacin for a single-use injection, and that should be a fantastic way to prevent things like TAS, because it's prepared sterilely, handed to the surgeon, put in the patient's eye, and that's it. And it's an excellent way of doing things. That's how we should all do them. But unfortunately, in other countries, it's not available to us.